Thank you, Colleen, and thank you especially to Rutgers for asking us to come back and talk to people about this really important topic. You may all have read that medicinal marijuana is a hot topic in the state of New Jersey right now. There's an awful lot going on. I'll answer what questions I can. I will say that there is much that is still unknown, and that is around the legislation that concerns adult use. And so on that side of the discussion, there's still a whole lot that I won't be able to answer. On the medicinal side, we've got that covered. We're expanding. We've got lots of great initiatives going on in this area, and I'm eager to talk to you about them. Let's see. There we go. Colleen already covered the objectives for our discussion today. And so I think I can skip through that. Our enabling legislation is known as CUMA, the Compassionate Use Medical Marijuana Act, which was enacted in January of 2010. In an administration that wasn't necessarily thrilled about the whole idea. And so it did take some time for the program to get off the ground. In September of 13, so somewhere in between, I think it was around end of 2012, we got our first dispensaries open. In the intervening year or plus, there were regulations that had to be written, lots of rules to decide on, and the places had to build out, grow, have their product tested and get opened. Very quickly, the legislature went back and amended CUMA to include edibles and remove a limitation that had been in the original legislation on the number of strains that could be offered. It was a very different time back in 2013. We didn't know nearly what we know now. And so the original legislation had limited the ATCs. And in New Jersey, ATC is the term that we use for dispensary. In this case, ATC means an establishment that does everything from seed to sale. So they grow, process, manufacture, and sell product. That'll all make more sense as we go along. So they amended it to include edibles. And it's important here, edibles is in quotes, because there's a real distinction between edibles in New Jersey medicinal marijuana terms versus edibles in the rest of the cannabis world. So in the rest of the cannabis world, edibles include things like chocolate bars and THC infused smoothies and things like that. In New Jersey, edibles refer to more medicinal category, medicinal type of food stuff, right? So it's not corner store food, but rather it's lozenges, it's tinctures, it's sublingual oils, things of that nature. And so sticking to the medicinal nature of the program, that's how we define edibles. We don't see on our horizon anyway, from a medicinal standpoint, things like shakes and infused drinks and chocolate bars, granola bars coming anytime soon. In September of 16, under pressure from primarily veterans groups, the governor added post-traumatic stress disorder to the list of qualifying conditions that were in the original statute, a real help for those, especially with PTSD. In March of 2018, the department and Commissioner of the Department of Health now, Commissioner Ellen Hall, signed off on adding 5 new conditions to those qualifying conditions that allow patients to make medicinal marijuana purchase in New Jersey. Significantly were chronic pain and anxiety. And later on, I'll give you some numbers about the increases we've seen based on the addition of those 2 conditions. We expected at the time that we could, at the time this administration took office in January of last year, we had about 18,000 patients total. We have more than doubled that already. And we expect that if we added no new conditions, we could easily get to 1 to 200,000 patients. Looking at other states who are demographically similar to New Jersey, we could get to those patient numbers with the addition of these conditions. As you can imagine, chronic pain, musculoskeletal, and anxiety are two very common conditions that are prescribed for. So in January of 2018, the governor's office, the sixth action they took, and it was very early on in the administration. I think they had only been in office for days, maybe weeks, directed the department through Executive Order 6 to have a look at the medicinal marijuana program in total and make recommendations for changes that we could make to increase access. Up until that point, the program had been very restricted. And so with a 60-day turnaround, the department released a final report, which included a number of recommendations in how we could increase access to patients and make this program more beneficial to those who need it. We sort of lumped those into three categories. There were those that we could do immediately through executive action, those sort of policy decisions that that could happen without a whole lot of red tape, if you will, or any other obstacles. And then there are regulatory changes, things that had to happen through the rulemaking process. And some of those we will soon realize with the publication of our proposed rules. You may have seen those if you're a person who follows those things. And then the others were the more heavy lift things that we needed the legislature's help to change. So the immediate actions that we took in March were that we expanded the conditions, and I talked about that already. We added 5 significant conditions to those that qualify patients. The fees for cards were reduced. So normally it would have costed a patient, it would have cost $200 for the MMP card that a patient's required to have. We reduced that fee, cut it in half to $100. In addition, we cut the fee for reduced or increased the categories of people that qualified for reduced fee cards. So seniors now get a $20 card, veterans get a $20 card. Anyone on government assistance, that card only cost them $20 as opposed to the $100. Likewise, we had lots of resistance from physicians who didn't want their names listed publicly on our registry. And that had been a requirement previously, so that patients had a directory, an online directory to go to so that they could find a physician who could write the certification that they needed. And some physicians were opposed. They did not want to become known as, the pot doc. We made the publication of their names on the registry optional. The good news was there weren't very many physicians who were looking for that option. And so the good news for patients is that our physician list still is pretty thorough, a fairly thorough listing of all the physicians who are available for patients to see. We had not had the ability for patients to access our registry except on a desktop or laptop computer. We changed that very quickly. Now it is available. Everything happens out of the registry, which you'll see as we go along. And patients can access that, physicians can access our registry on tablets, cell phones, any of the usual mobile devices. We also issued a waiver to our existing ATCs, allowing them to open satellite locations. Recognizing that we needed more access points, we invited each of them to propose up to 2 additional sites that they could get up and running. And then we allowed 2 caregivers per patient. And so where it had been restricted to 1, we recognized the need for patients to have the option of more than 1 person to help them out if they're unable to get to a dispensary and make a purchase. There are a couple of key things to remember about cannabis, about marijuana in general, that inform the entire discussion of medicinal marijuana. And that is that it is still federally illegal. And that causes all sorts of problems, from patients' ability to travel and take their medicine with them, to funding in nursing homes should a patient there decide that they'd like to incorporate cannabis in their therapy. Marijuana can't cross state lines. Again, in a state like New Jersey, it's very easy to jump across state lines. You may work in one state and live in another, or have family who lives just across the river, and that makes it difficult. It's still considered a crime to cross state lines with marijuana. Very significantly, this is a cash only business. There are very few credit card companies that will service marijuana businesses. There are very few banks that will provide loans to the folks who want to start one of these businesses, and so you can imagine the difficulties that presents. Patients must carry large quantities of cash when they go to make a purchase. The business people who want to open these places have to rely on private investors because they can't be loaned money by an FDIC insured bank. So it gets really tricky when you consider that factor. Medicinal marijuana's use is prohibited in public places. Again, makes it sort of difficult for patients who need a regular regimen of therapy. And last but not least, the statement that makes our legal people happy, which is we don't make policy with regard to use in private businesses. We have questions continuously flowing to us regarding the administration of medicinal marijuana. So a patient comes into a nursing home, a hospice facility, a group home, a school, any number of public institutions, and a medical or healthcare professional there has a question: can they administer the medicine for the patient or for the caregiver? And this is still such a difficult area that we're dealing with, that what we recommend to everyone who asks this same kind of question is that they consult with their particular organization's legal counsel and make a decision for their organization. Sometimes it has to do with federal funding. Sometimes it has to do with, in the case of schools and administering to kids, it has to do with, lots of other issues around, patient care and minor rights and things like that. Unfortunately, we can't guide you specifically there. So here are some of those numbers. We are currently at 39,300 patients. That's more than doubled since the administration began. 23,000 of those patients that have registered with us, are registered with one of the new qualifying conditions. You may have heard about the Grand Rounds lectures that are happening around the state. The commissioner was just in Atlantic City yesterday, providing that Grand Rounds lecture for physicians and clinicians there. That has helped us to educate physicians and care providers, and increase the number that are available to help folks with their certifications. We have 1,600 caregivers on the rolls. These are folks who are allowed to make purchases for patients. We currently have 6 operating centers, operating ATCs, and 6 newly licensed. And so that was December 17th, I believe, was the announcement of 6 newly awarded licenses. And we're excited to get those folks started. In fact, this afternoon, we're meeting with the new licensees to start talking details about construction, when they can open, and that sort of thing. So it's an exciting time here to increase access to people. And we've had 4 of our ATCs request to expand into additional locations. Just checking the sound here, Colleen. We're still doing good?
Sorry, Susan, I was muted. Yes, you're.
No, great. Okay, good.
Sounds terrific. Yep.
Yeah, when you're not in a live room, it's difficult sometimes to tell. Thank you.
No, you sound. You're perfect.
Thank you. So, some of our demographics that might be of interest, our top 5 conditions are listed here, and intractable skeletal muscular spasticity remains by far the most diagnosed condition of our patients. And then severe and chronic pain, which was just added in March of last year, you can see comes in second. We have a number of patients with PTSD. Our age group, our age breakdown regularly surprises people. There are people who, lots of folks who believe that it's probably a younger group, a younger audience for medicinal marijuana. And what we find is over 50% of our patients are over 41. And to me, that kind of makes sense, right? You've lived enough life that these conditions are those that catch up with you after time, over time. And then you can see our gender breakdown is nearly half and half. We lean slightly more for males. Now I'll keep going. I think I've got a question, a pause for questions just after requirements and eligibility. So physician requirements are fairly easy. A physician has to have an active medical license, we would expect that, an active CDS registration to be expected as well, and have a practice in the state of New Jersey. That's all that a physician needs to do or have in order to be able to participate in the MMP, the Medicinal Marijuana Program. Like I said, we repealed the requirement for a public listing, and so a physician can opt out of that if they wish. Physicians don't have to just come into the program to certify people for medicinal marijuana. We have physicians who come after one of their patients develops a condition, and together they decide that cannabis is a therapy for them. And then we have other physicians who specialize in pain management and cannabis as a therapy for that. So we have all different kinds of physicians. I always say it takes no more time to register as a physician with the MMP than it does to create an account for Amazon. It really is that simple. You come into our registry, enter your name, address, practice information, and hit send. There's a short review by staff here to ensure that the medical license is active and unencumbered, and that the CDS is clear, and the physician is ready to go. We have a number of options for education that we can provide to physicians. Unfortunately, they're not as deep as we'd like. We recognize the limits of research right now, and that's another thing that the department's working hard on is to really get the research side of this industry moving, so that we have more data to inform our decisions, more data to educate patients and physicians with. Patient requirements are pretty straightforward. I say that with hesitation because we do hear from patients who have quite a difficult time with this. I will say this: we have a small army of people manning the phones, ready to help people get registered if they have difficulty. Very often it comes down to the technical issues. There is a document upload that's required, and there are some folks who are not very well versed in taking photographs of documents with a phone and then uploading them into the computer. We have folks that can help with that, though. So a patient, of course, has to be a resident of New Jersey. That's statutory requirement there. And they provide proof of residency. That most often comes down to providing a driver's license. I'm going to skip down. They have to be diagnosed with a qualifying condition. I think that's also a given. And that happens, by the physician. We are a physician-driven program, and so all of this starts at the physician's office. Then they have to establish a bona fide relationship with a physician. So you have to live here, you have to have a qualifying condition, and you have to establish a relationship with a physician. The way that you can establish that relationship, by rule, as one of three ways. And you see that two of these are much smaller and listed in blue because we are working diligently to change this requirement so that we don't have three options, but that we have one, which comes more in line with traditional, traditional medical protocols, which is, you see a physician, they do a thorough examination, medical history, physical examination, and they assume responsibility for your care. That's the way it works for every other condition in every other scenario. We currently have this rule that says the patient-physician relationship must have existed for at least 1 year, or the physician has seen the patient at least 4 times, or the normal way, if you will. So like I said, we're working hard to eliminate the first two options here. We just don't see that they are in line with a traditional physician-patient relationship. Our current conditions, I will post the slides for you to see, and I won't bore you by reading through these. The top 5 that are in red are the ones that were added in March of 18. The others were included as part of the original statute. We now, I think there are 18 of them now. They take up 2 pages. You'll see that some of these had qualifiers like seizure disorder that was resistant to conventional therapy, or PTSD that's resistant or intolerant to conventional therapy. And there is some move to push cannabis to the forefront, meaning it's not a last resort, but rather the first option for folks in any of these situations. So each patient is eligible or entitled to have a caregiver or 2 caregivers. And the most important difference to think about, there's a list of requirements for those caregivers. Some, are pretty standard, again, be a resident or over 18. But the primary difference is that caregivers are required to have a criminal history background check, whereas patients are not. And the thinking behind that, the justification behind that is we want to ensure that we don't have caregivers who are sources of diversion, right? So the initial motivation behind the legislation was that we vet these folks so that we ensure the safety and integrity of the program. So a caregiver will have a criminal background check, meaning they go get fingerprinted. It's an additional $60 or $70 fee. And they also get a card. And what that allows them to do is go to the ATC, make the purchase, and transport cannabis to the patient without fear of any arrest or anything from law enforcement, because this still is a Schedule I substance. It would be illegal otherwise. And so caregivers currently can be a caregiver to only one patient, except in the case of minors. Minors, we allow a parent to be a caregiver to multiple children, and we allow children to have multiple caregivers. So, not reliant on just one parent to help care for that child, whether they're at school or anywhere else. Okay, so here's a pause for questions. Are there any questions on anything we've covered so far? Eligibility requirements, the law in general?
Thank you, Susan. We have one question that I think you might be addressing later. So if that's the case, please say that. What is the process for monitoring marijuana labs, and are there consequences if they're involved with illegal activity, and any restrictions on herbicides, fungicides, etc.? Is that?
Yep, absolutely. We're going to talk about lab testing in more detail later.
Okay, let's hold on that one.
Okay.
Another question regarding requirements of all other traditional MD-patient relationships are not involving a medication that has not been a prescription and has had a history of long-standing societal illegal recreational use.
That is true.
I'm not certain what this question is. Cannot be compared to treatment for other disorders which
Yeah, that's true. I get where that's coming from.
okay,
I mean,
well,
when we talk about the physician-patient relationship in terms of cannabis or marijuana, as opposed to other traditional medications, it doesn't really fit the bill,
understood.
because it's an illegal federal Schedule One, substance that has all sorts of taboos and social implications associated with it. And so I think I understand that the comment, which is there really isn't a compare to be had there.
Understood. Right.
Yeah. What we look at my point in that section is just that we try to mirror a traditional physician-patient relationship to the extent that we can. And so, we're trying not to put any more burden on the patient or the physician, and trying to, to keep in mind that that's our medical model.
Got it. Thank you. The next question, I think, is asking if RNs are allowed to be in the program. And I suspect that might mean nurse practitioners who can write prescriptions or physician's assistants who can write prescriptions. And I'll take it broader for that matter. Are there any limitations on the type of physician that can write such a prescription, as well as nurse practitioners or PAs?
Yep, got you. So currently, the only restriction, if you will, on physicians is we are restricted to MDs and DOs.
Okay.
Those are the two.
No nurse practitioners, no PAs at the moment.
And at this time, there are no nurse practitioners. There is the Department of Health is in full agreement that they should be included. That's a statutory requirement that we need to work on through the legislature and with the BME. I haven't heard that there's anyone opposed. It's just a matter of getting that done. And so I think we will see that coming.
Thank you. And two last points and we'll move on. Your presentation is addressing medicinal marijuana, and does any of this pertain to industrial hemp or CBD?
No. Very interesting distinction there. So the state just passed a law, the feds just passed a law too. The Department of Agriculture in New Jersey is currently working on a set of regulations dealing with industrial hemp or industrial cannabis. It's an entirely different topic, not an entirely different plant. It's like, same genus, different species. And CBD is interesting. I think I get asked more about CBD than I do anything else. CBD is present in both plants. The difference between the hemp CBD and the cannabis marijuana CBD is the concentration of THC, the other major component, chemical component in the plant. So CBD is not necessarily federally illegal. It's pretty complicated. You've got to look at U.S. Farm Bill rules and be very careful about the certificate of analysis on where the CBD is coming from, et cetera. But that's a different, completely different topic and subject matter than medicinal marijuana.
Thank you.
So,
just a point of clarification regarding the question earlier about RNs participating. What I think they meant is, can an RN participate without repercussions? I think you may have referenced that earlier, but can you clarify?
Yeah, another good question. So we have received that question also many times, and from many different healthcare folks in different roles, direct patient care, not direct patient care, and I think it is more broadly categorized as employment protections, right? And employer-employee protections in this industry are a bit lagging behind, right? So we've got medicinal marijuana out there, but we haven't really dealt with employee protections yet. What we have so far is case law, and the case law that we have favors the employer. Each individual employer is at this point is responsible for making their own decisions about testing, about which kinds of jobs would lend themselves to a person being an MMP patient or not. So let me say this. No one advocates for use on the job, right? We all agree on that. No one advocates for a person being under the influence while on the job. We have heard of a number of people, more than a few, who have been tested as a regular part of their employment contract and have been suspended or fired from their jobs because they test positive for THC. It's the employer's prerogative to deal with that how they wish. There are employers who, as long as the employee is able to perform the functions of their job and are not under the influence, if you will, while they're on duty, while they're on the job, are fine with that. And there are employers who take a zero tolerance stand. We don't have any specific rules yet. So that's a tough one. I don't really have, a definitive answer for you there. I can just tell you what the landscape looks like now. There have been a number of prominent cases, public works people. We had a funeral director, a funeral home employee case that made news in New Jersey. The employee had an accident with a company car. And of course tested positive, but not under the influence. That's a really, really difficult area.
Okay, thank you. That was the last question for this section.
There's no rule right now that specifically prohibits anybody from participating. That said, check with your employer about what their rules are.
Great. Thank you, Susan. That was the last question for this section.
Okay, great. Thanks. The registration process is next, and this sort of brings together all of the pieces from the requirements section. The first thing that a patient must do if they're interested in participating is establish that relationship with a physician. And so, be diagnosed with a qualifying condition, talk to the physician about potential benefits of cannabis therapy for that patient and their condition. It's the physician, this is how it all starts. The physician certifies the patient for MMP eligibility and sets the quantity limit in our registry. So the physician's office comes into our online registry, enters patient demographics and a qualifying condition, and enters a certification period for the patient. Unfortunately, this slide doesn't fit well no matter what you do. So I'm going to flip over here real quick. The physicians can certify a patient for 30, 60, or 90 days. Most of them out of, in the interest of the financial interest of the patient, write the certification for 90 days. What happens is the patient has to come back when the certification expires. And so most physicians choose to do 90-day certifications. In addition, if I go back again, the physician sets a quantity limit. Now, a patient can receive up to, the law requires up to 2 ounces per month. And so for that 90-day period, they can certify for 2 ounces 3 times. The patient then gets a reference number from the physician. They go into our online registry and they complete their part of the registration process, which means they upload the required documents, a license. We need to know ID, who they are. We need a picture to put on their card, and we need to prove residency. If they qualify, if the patient qualifies for a reduced fee card, we ask them to upload proof of government assistance or veterans benefits. And then the patient chooses which ATC they'd like to go to. We ask them to indicate in the registry which one they want to go to so that we can sort of plan for supply and demand. They're not restricted in any way, though. They can visit any ATC at any time. When they arrive at a new one, the new ATC can change the patient record. the patient can change it on their cell phone on the way there. They're not restricted in any way. And then patients and physicians can monitor usage in the registry. So it will show of the maximum 2 ounces in a 30-day period, what was purchased on what date, and so forth. When I say what was purchased, I mean just in terms of quantity. We don't track at our level anyway the strain type or the content, the cannabinoid content, chemical makeup, if you will, of what they're purchasing. Those records are available through the ATC. The patient is issued a card. They pay a fee. They're issued the card. These are examples of what our cards look like. Most prominently is what the patient card looks like. You'll see the purple one is a caregiver card. And basically, this is the ID required if a patient encounters law enforcement or anyone else who wants to understand why they're carrying cannabis or paraphernalia or whatever else they have. I think we can keep going. I'm not so sure that there's going to be a lot of questions on that process. We'll take a pause in a few. So how to qualify patients, locate a physician. And like I said, this is all available on our website. We work diligently to keep our website up to date, relevant, and full of useful information that's updated regularly to really help folks out. So our goal is to have a website that is really helpful for patients. So when you get to our website, you see this blue bar across the middle, and there's a patient-focused, physician-focused, caregiver-focused. And so patients go to the tab for them, and the drop-down menu says Find a Doctor. When they click on that, they're presented with a page that looks like this on the right, and I'll zoom in here so you can see that. They can search by specialty, the doctor's name, a city. They can click on the county of interest, and they will receive a listing of doctors. This interactive map is a pretty good tool. The physician listing that comes up will help them with, address, phone number, and specialty as well. So if they're looking for a specific, oncology specialty or something, they'll be able to find that. As always, we would recommend that a patient talk to their own care team first, and then use our list if they need to. Locating alternative treatment centers is just as easy. There is a listing on our website. We currently have 2 in each of the 3 regions. So we're divided north, central, and south. We currently have in the north, Montclair and Secaucus. In the central, we've got Woodbridge and Cranberry. And in the south, we've got Belmar, Camden County, and Egg Harbor Township. Like I said, we're adding 2 additional ones in each region so that we will bring our total to 12. We realize here at the DOH that one of our challenges is increasing access. I always say if there were only 6 places in the state to have your car serviced, everybody would be up in arms. We need more access points. And so we are working really diligently to make that happen so that folks don't have to travel an hour or 2 hours to get to their local, to their nearest ATC, I should say. When patients go to the website and click on alternative treatment centers or ATCs, they're presented with this list. And again, it gives them a rundown of exactly where the current 6 are. And then, as they get open, we'll update to the additional 6. So here's some information about the testing that someone was asking about. All the cannabis grown by our suppliers is tested. Generally, there is a test, not generally, the requirements are that there's a test when a strain is initiated. So marijuana isn't marijuana. There are hundreds of different strains. Each one has its own specific chemical profile. The 2 most important compounds that most folks look at are CBD and THC. And if you want a reminder to help you remember which is which. THC is the high causer, and the one that causes the psychoactive effect. CBD is beneficial for things like seizures, or it's a great anti-inflammatory. It has other properties like that that are not psychoactive properties. So our lab tests each strain at its inception. So first harvest of a strain in one of our ATCs is tested for its initial cannabinoid content and for the presence of molds, heavy metals, and pesticides. There's also a visual inspection for pests of any kind, that sort of thing, and for the structure of the plant. We also do quality control tests, which amount to, at regular intervals, our inspectors go into the ATC and grab at random a package off the shelf and send it to the lab for testing, to see how the cannabinoid content compares to our original sample, and again, to ensure that there are no heavy metals, pesticides, or molds present in the product. We've conducted 98 tests on 98 distinct strains so far, and there are plenty more strains that we could be testing. All of that information is contained in a strain library, which is available for the time being. It's behind the login on our registry. So it's available, readily available to physicians and patients to have a look at. We are considering the value of putting that information out just publicly available regardless. But for now, it's restricted to the folks who are registered in the program. That library contains the actual test results for any of the strains that we've tested. And our current 6 ATCs are offering 65 different strains. 11 of those are high CBD strains, which means that they are relatively low in THC content, and primarily would be used not so much for the psychoactive benefits that come along with THC, but for the other benefits that go with CBD. So this conversation about THC and CBD could take us the next 3 hours. So I just want to touch on that. I don't want to leave anyone with the impression that the only benefit of THC is its psychoactive effect, or that the only benefit of CBD is its anti-inflammatory quality or its anti-seizure properties, et cetera. The two things work together, and there's a phenomenon known as the entourage effect. There's tons of research, some new and some very credible, some more anecdotal, about how these two main compounds work together. In addition, there are at least dozens of other cannabinoids present in the plant that work in ways that I don't know that we all fully understand yet. But there we go. The two main compounds of interest to people are CBD and THC. And so what happens is, I just want to take a look where I was going next. The plant can inherently have different ratios of those compounds in it. So you can have a plant that's very high in THC and very low in CBD. You can have other strains of cannabis that are the reverse. And then you have hybrids, which have varying ratios of each. And it's up to the patient, the physician, and the counselors at the ATCs to determine which ratios, which properties, and which combinations are most helpful for a particular patient with a particular condition. Now, there are some physicians who leave it to the patient and the counselors at the ATC to fine-tune that, and there are other physicians who are very up on all of this, very involved in these decisions who have very specific recommendations for patients. When they go to the ATC, they want them to have, a 50-50 THC, or they want them to have something higher in THC or higher in CBD. The only thing I can say for sure here is that for the most part, the minors are getting high CBD strains. I think there are many folks in our program of a more advanced age, those into their 80s maybe or 90s, who are also interested in the higher CBD strains, and a lot of that has to do with the social attitudes around cannabis. So let me take a pause there and see if there are any questions up until now. What comes next in the presentation is a review of the types of products that are available, and a little bit more discussion about the effects of the compounds in cannabis.
Thank you, Sue. I think you actually addressed a couple of the questions that folks were asking about how an MD might specify the ratio between the THC and CBD.
Mm-hmm.
So I'll ask those again. But there are a couple of questions. One is there a minimum or maximum level of THC allowed? I guess maximum is more than.
Yeah, great question. Great question. Currently, the statute allows for a maximum of 10% THC. That is, so what the test results show and what everyone looks at is THCA. So this is the chemical process that happens. I'll try to explain it in as general terms as I can. So THC inherent in the plant does nothing psychoactively until it's heated. And once it's heated, I'm not a chemist, but it drops a molecule, becomes THCA, and that's the compound that causes the psychoactive effect. So if you have raw plant material and you eat it, you could eat lots and lots and lots of it, nothing's going to happen because the THC has not been, and they call it decarboxylated, which means heated. So the edibles that we have, lozenges, et cetera, in their manufacture, the THC is, the material is decarboxylated to release that THC content. When the plant material is put in a vape device or smoked in a pipe or rolled up and smoked in a cigarette, that's how the heat is applied and it releases the THCA. So it's an important distinction because when you look at test results, you will see test results for THC and THCA. Our limit on THC is 10%. However, what we're looking at, what's published on the ATC materials that they give patients, and what is on the label of the product they carry out will be the THCA content, which is the percentage of that compound that will affect you. And those go anywhere from 8% very low to 28, 29% very high. So I hope that wasn't too confusing, but there is an important distinction there. We have a 10% limit, but the thing to look at is the THCA content.
Great, thank you. Two other quick questions. One is, have there been many cases where fake IDs have been presented? Is that an issue at all?
There have not been many cases. We've had a few, but not many.
Okay, and then also, if medicinal marijuana is being used as a treatment method for mental health issues like PTSD, which is classified as a disability, wouldn't employers terminating people for testing positive for THC be reasonably considered as discrimination? Yeah.
Again, employer protections is a really difficult. I don't know that I can lend any clarity here. This is a thing that's working its way out over time through various means, right? Through, I'm sure the ADA will have something to say about it. The legislature has weighed in. Employers are weighing in with the costs to their businesses. So, there is the potential for that for sure. The folks who are arguing this point very often point to coworkers who are taking any number of prescribed medicines that might leave them not, necessarily the clearest thinking individuals. And why are they being discriminated against? Because their quote script happens to be for cannabis. And the argument's all over the place. I don't know that I can help clarify that one very much at this point.
Okay, thank you. I will ask one more. What about malpractice insurance considerations with prescribing it? Have there been any issues arising?
No, none that I've heard of.
Okay.
No, we've heard nothing from the physicians about that.
Okay, and sorry if there is a follow-up to this, have there been any prominent criminal repercussions for physicians since federally it's illegal? And is there state law that might protect the physicians in a state where it is legalized?
That's more a question for the folks at the BME, because they're, that's kind of out of our lane, right? The BME are the ones who regulate, all issues around physicians. That said, I've heard not a single physician has come to us and said, "Oh dear, there's, federal implications here." Or I have people knocking on my door going, "Hey, what are you doing?" We did have a physician who was asked to move his practice from a building in which the landlord did not want marijuana business conducted in any of his buildings, and so that physician was, had to find a new place, physical place to have his practice.
Okay, thank you. You can go ahead and continue.
Sure. So usually in my in-person presentations, when we get to this section, I go, "Sorry, I didn't bring any samples." So we'll talk a little bit about products, the various forms that are available, and what might be on the horizon. The very first slide here talks about, just in general, the different forms. So bud, also known as flower, is the most prevalent, and those are usually, flower is usually the most prevalent term used to describe raw plant material. And so what many people don't understand entirely, there's believe it or not, there's a whole lot of folks out there who have absolutely zero experience with cannabis at all. I think everyone assumes that everybody in their teenage or college years must have had some sort of exposure, but there are lots and lots of people who don't. We hear from them every day who say, "Please explain this to me. I don't get it." So there's this big bushy plant, 98% of which, maybe, I don't know, a huge percentage of which is just trash. So the stem, the stalks, and all those great big 5-leaf, 7-leafed structures that come off that plant are absolutely of no use when it comes to medicinal marijuana, any kind of marijuana, which surprises some folks because they think it's the leaves that get ground up and smoked. And it's not. Those leaves get pulled off mostly during the growing process to allow the plant to focus all of its resources on the flower, which is the bud, which is this small conical shaped structure at the ends of branches. And the growers pull off all the fan leaves so that all the nutrients are directed toward the flower, the bud. And it's those that are snipped off, dried, cured, and contain all of the resin, which is where all of the medicinal quality lies. I think I've got a photo that I can show you that a little bit. So that flower, that bud, can be put through an extraction process and have its oil, its resin extracted. That can be done in a bunch of different ways. The most prevalent way, I think, at least here in New Jersey, is CO2 extraction. And so then there's this raw resin material that can be this raw resiny substance that can be formulated into any number of different products, like a lotion or a topical or a lozenge, or put into a vape cartridge. Now, the extracted resin is so potent that it just takes a small amount in any one of these things, and so then it's mixed with something else to make up the volume. So in a vape cartridge, it's mixed with glycerin or a number of other substances, which become the carriers of this resin and its THC and CBD. It can be mixed with this sort of waxy substance that these lozenges are made of, pressed into a lozenge that is easily dissolved under the tongue or chewed up like a I'm trying to think of what they compare to. They're sort of chewy and waxy, not unlike a gummy bear. And so there's a number of different things. The one thing that I think is very important that I like to point out at this point in the conversation is that there's a huge difference between smoked and eaten cannabis. And this is another point that we try to make sure we really educate patients about. They can go into an ATC, buy flower or bud material, right? This plant material, and smoke it in any number of ways. So it can be put into a vape device, it can be put into a pipe rolled up as a cigarette, etc. And there's a certain effect that comes from smoking it. They can also ingest it, and there's 1,000 different ways that this can be done. Many people prefer this method because it's more discreet, because they can microdose. They can take much smaller quantities of the cannabis over time and achieve the benefit of having the effect be less than and longer, right? So if it's pain control, it's enough to manage the pain that lasts over a much longer time. If you're smoking, you get this immediate relief, but then there's a much quicker drop off. And so this important graph illustrates the point that every single ATC makes with people, and that is to start low and go slow. And so what that means is start with a low dosage and take your time and see what the effect is on you, because everyone experiences this differently. I usually talk about the canna tourists who go to places like Colorado or Washington or Oregon, where cannabis is fully legal, and they show up on the plane and grab the cannabis map and head to the nearest dispensary and buy up a bunch of chocolate bars. And this party bus will take you to from place to place in a rec environment, and they eat a few squares of the chocolate bar, and they think this whole thing must be a great big swizz because nothing's happening. I don't feel anything. And then they eat a few more squares of the chocolate bar, and they're still a little disappointed because nothing's happening. And then what ends up happening is, half an hour to an hour or so later, they have ingested so much cannabis, they begin to feel really, really bad because it takes effect over time. We have had patients who go into dispensaries and either don't quite hear the information properly or get confused and have similar experiences here. We're very, very careful to make sure we explain these differences to folks. There are people who benefit from both options. Some need a quick onset of the effects. Folks with anxiety, perhaps. Folks, in any number of situations, seizures, may need a quicker onset. Some folks prefer smoking. As the Department of Health, we advocate for non-smoking methods for obvious reasons. And so there you go. The microdosing and allowing a low-level medicinal effect over time, I think, really makes sense for lots of people. Okay, that's it. On the left, what you see is one of those buds. And so this is the structure that sits atop the stems. These are the things that are the base of what we do. On the right side, you see that same bud trimmed down into smaller pieces. And so what happens is you're trimming out the stems and small leaves, things that aren't going to contribute much to this particular kind of product, which is generally ground up, put in a pipe or into a cigarette and smoked. I don't have a zoomed in enough photo, but if you look at the structure on the left, what you'll see is it looks kind of fuzzy. And when you zoom in on that bud, what you see are hundreds of what look like small mushrooms. They're called trichomes, and they're these little structures that contain the resin. And so when you handle this, your hands become very sticky. The scissors that you used for trimming become very sticky because it's that resin that contains all the cannabinoids that's coming off on your hands, on the scissors, whatever. So price is an important conversation, which we'll have as well. The bud from the previous slide is the premium product. I think more so based on folklore than anything else. Folks just prize that, put a higher value on that than they do on the same thing, which you see in this bag, which has just been sort of broken down. So through handling and the bins of this, in this case, think of the crumbs at the bottom of a potato chip bag, right? And so there were folks that would place a higher premium on these whole buds versus the crumbs that were left in the bottom of the bin after the stuff was handled and trimmed, et cetera. We find in our lab testing there is little to no difference in cannabinoid content and medicinal value between the two. This is called shake. Generally, the crumbs that are left at the bottom, and shake is offered usually at a lesser cost. So what are those costs? The product is sold in 1/8 and 1/4 ounce quantities, and an 1/8 of an ounce now is somewhere in the $50 to $60 range. Quarters generally go 100, maybe less. It depends on lots of things. So for the most part, we are in New Jersey somewhere around $400 an ounce. Black market price, everybody always wants to know how it compares, is usually $350 and up. Again, depends where you are, what you're buying, from what source. There's a lot of different factors that affect the price. The cost of the program is one of the things that we hear the most complaints from patients about. And part of what we're trying to do, in addition to increase access by bringing in new ATCs, is to increase competition so that we can drive market price down and make this more affordable for patients. In addition, we have to continue the conversations with insurance companies in order to get some assistance from that side. Physicians are free to charge what they like for patients to come in and establish that bona fide relationship. Some of them charge about $100 a visit and hold to the rule of having 4 visits to establish the relationship. And so it can cost $400 to sometimes $650 for the patient to establish the bona fide relationship with a physician. There are physicians that do this for much, much less. And again, remember, this is out-of-pocket expense to the patient. They then have to pay a fee for the card that's issued through our program. And that's either $20 or $100, and then they have to go buy the medicine. And at, we'll call it somewhere in the neighborhood of $400 an ounce times 2 ounces a month. You can see how the fees begin to pile up. We are laser focused on attacking that issue from a number of fronts. We realize that this is expensive. Part of that is not going to change until it becomes, conventionally accepted therapy, and until the insurance companies change their stance. But the price discussion usually comes up at this point, and unfortunately, what I've laid out is about what we're looking at. So that plant material, when it is extracted, ends up being this thick molasses-like resin that you see on the bottom left. On the top left, what you see is a joint, a cannabis cigarette. They do offer them pre-rolled at some of the ATCs. For those that have dexterity issues, they don't have to worry about, or lack of experience, they don't have to worry about trying to get to this point. They will offer them pre-rolled. They tend to be more expensive because of the labor involved in doing that. The extract that you see on the bottom left is this extremely potent material that is then, diluted in whatever else it is to make other forms. So on the right, you see oil, which can be put into foodstuffs, which can be put by dropper under the tongue, which can be incorporated into a juice box, any number of ways that you can use this oil. It can also be put into a vaping device. Here you see examples of the lozenges, and they've improved tremendously since the beginning. These look very waxy and very unappealing. They've improved, and they've gotten much better with their flavorings to make these more palatable. On the right, you see a sample of one of our vendors' lotions, topical formulation. On the left, that is not a syringe. Let me not go into medical terms. That's not meant to be injected. This is the most efficient way to dispense this thick oil. And again, mostly intended to be used topically. We have opened up some of the rules that allow this to be mixed with other things as well. On the right is just another topical formulation. It's a stick that sort of winds up and allows you to apply to the skin without, making a big mess. Newest in our list of approved products are these vape cartridges. A great alternative to smoking because you don't have the same combustion and the chemicals that come from the combustion that you have with smoking. This device heats that oil at a lower temperature, high enough to release the THC, but not so high as to cause the burning of anything. There's cartridges like the one on the left available that you screw onto the top of a battery, and some of them are refillable, some are not. And then on the right, you have a self-contained vape pen, which is the battery and the liquid is inside. The whole thing is self-contained, and you activate it simply by drawing on it, and then it produces the vapor. I think that's it. So I'm available for plenty of time here to take as many questions as we have, Colleen.
That's great. Thank you, Susan. And there are questions.
Sure.
So I'll start with our first one. Do physicians ever recommend or regulate daily dosage or frequency for patients?
They do. There are some that are very specific about the strain type, the cannabinoid profile, and method of administration and dosage, and they provide those instructions to the patient along with their certification. So there are some docs who do that.
Great, thank you. Does health insurance cover physician visits to establish a bona fide relationship?
Yeah, they don't, and that's a thing that we're working on. The theory here is insurance companies don't distinguish in any other situation whether they're going to pay based on what therapy is recommended, right? So it's not, do we try physical therapy first, or do we put you on NSAIDs or anything else? We're trying to get, this is an uphill climb. We're trying to get folks, in the insurance world to understand it's a doctor's visit like any other doctor's visits.
I'm shocked at your answer.
the particular therapy might not, be something that they want to tackle right now, but the physician visit alone is something that should be cut. Right now, it's not. I know of. I don't think we've had one instance where we've had a patient. Maybe we have. We've had a few, just a handful of patients who tell us that their insurance companies or their doctor's offices are able to bill it, and they're responsible only for the copay. But they are few and far between.
Huh. Okay, thank you. Is medical marijuana approved for use by pregnant women?
Yeah. Well, there is no prohibition. How about if I put that out there? So we have no specific rule that prohibits its use. And we wouldn't tackle that because that's something that would be left to the physician and the woman, right? I can tell you that ACOG has guidelines that say it is not recommended.
And what is ACOG? Can you clarify?
Association of American College of Obstetrics and Gynecology, I think.
Okay, thank you.
In his grand rounds, I think that's right. In his grand rounds presentation, our commissioner specifically addresses pregnancy and cannabis use, and as a physician himself, says it is not recommended. I'm sure there are specific cases when it's appropriate, and again, it's a decision to be made by the woman and her physician. The MMP doesn't have rules that specifically prohibit it.
Okay, thank you. Next question is, in New Jersey, will the marijuana be grown outdoors on farms or only indoors, or both, I guess?
Either. They can do either or. Right now, the original 6 ATCs all grew indoors. Our new licensees, at least half of them, have proposed greenhouse operations. There's one of our originals that's also looking at a greenhouse operation. And so it's both. They can do either or.
Okay, thank you. There are a couple more. How involved is the state of New Jersey's program in getting federal legislation passed to remove cannabis, excuse me, from the FDA Schedule I list?
I'd say at this point we're sort of peripherally involved. We're not involved directly in any of the conversations.
Okay, that's fine.
Yeah, I think I'll leave it there.
Is there any minimum age at this point for patients to receive a prescription?
No. So minors, we do have, this is about 1% of our patient population are minors. There are different rules for minors, caregiver rules, et cetera. At this point, the state requires that, the statute requires that a minor also have a psychiatrist statement. We're working to have that eliminated. So the original law said not only for a minor do they have to have the physician certification, but they also have to have a psychiatrist certification. And then, beyond that, it's really just, over 18, the rules are different for your ability to go in. You have to be 18 to go into an ATC and make a purchase on your own without a caregiver.
Thank you. I'm going to go back to some follow-up questions that had come up earlier.
Sure.
Since we have the time.
Yeah.
There was someone had asked earlier about the questions of criminal repercussions for physicians since it's federally illegal. Can you comment on the impact if there's an issue for participants? So for the patients, has there been any criminal repercussions?
Yeah, so there's a lot of news stories around this as well. So, if I'm honest, not every law enforcement group is as up to date on the rules as every other one, and so sometimes we receive phone calls from patients who have encountered law enforcement personnel who are not completely up to date on what the rules are and how they apply. And generally we get through that without any major repercussions for the patient. Usually it's just a matter of explaining to law enforcement, et cetera. There are still some gray areas. I mean, there was one particular news story of a couple of patients who were at Seaside Park and wanted to medicate on the boardwalk. And law enforcement, just shut that whole idea down very quickly. And so there was some back and forth between the patients and the law enforcement folks about what constitutes a public park. Because the rules are clear. These were well-educated patients, and the rules are clear about where use is prohibited, and it says on public transportation in public parks. And they asserted that the boardwalk was not a public park, and Seaside came back and said, yes, it is, and changed some of their local ordinances to make it a public park. And, so we have things like that. We have patients who don't quite understand the rules entirely and end up having some issues with law enforcement. But for the most part, the rules are what they are, and everybody gets along just fine using them as intended, I guess. It's for the patients, the most the safest thing is to medicate at home or in someone's home, at someone's residence, right? Because of the nature of the product that we're talking about and its status, its Federal 1 status, Schedule 1 status. That makes a difference. But for the most part, we don't have patients calling us regularly saying that they've had run-ins with law enforcement and they're being arrested and things like that.
Okay, thank you. I'm going to combine a couple of the questions that are here. One is that, would there be any way to determine if someone is abusing their prescription? And the one I'll add to that is, can a participant's card be revoked? So I guess for either abuse reasons or something different. So
participants' cards are revoked. It's not common because, this is a medical therapy. And so, we have to be careful. But we certainly have had cards revoked. People have tried to give us false ID, or we've had folks convicted of distribution. I mean, what normally happens is someone has a card, an MMP card, and is distributing product that they obtain elsewhere, right? It's usually not program product. And when all of that happens, generally we don't hear much from the patient anymore after that. But the statute provides for us to discontinue, deactivate, inactivate, or disqualify. There you go. Disqualify a patient for a conviction on any CDS or drug charge. So that has happened. We've had to do that. What was the other part of that question?
With abusing a prescription?
Yeah, so, there are limits, right? 2 ounces per month. And it's impossible for a patient to go into an ATC and purchase over that amount. Our registry is accessed by everyone involved in the cycle, the physician, the ATC, and us. And so when a patient would try to make a purchase over their allotment, and it's not always 2 ounces a month. Some physicians certify for 1 or a half, or anything up to 2, and so it's impossible for them to make a purchase beyond their allotted amount. Now, then there's the black market, and so then it becomes really the physician who's looking out for potential abuse. I do believe we have some really astute folks in the ATCs as well who might informally talk to that person about, their tolerance building up, right? We have that happen to people. We have had a patient present at an ER with cannabis hyperemesis syndrome, which is indicative of long-term heavy use. And so that really is the thing that we defer to the physicians to deal with patients on. It is difficult to spot, but those who are trained in the ATCs can spot it. And then, of course, that's between the physician and the patient.
Okay, thank you. 2 last quick questions. When do new laws go into effect for cannabis deliveries services? Is that something that's
Yeah,
in
delivery,
process?
we'll get there. We're not there yet. We don't have anything proposed yet. Some of our rule changes include, we have a number of different rule changes proposed. Those are available on our website as well. That does not include delivery yet. There's a whole lot of pieces to that process to be worked out. We've got to figure out how to license delivery people. We've got to ensure security, and we're not quite there yet. We'll get there, but we're not there yet.
Okay.
Our caregiver process is really the process by which we enable a patient to have someone else get product to them.
Okay, thank you. And lastly, since many people in our audience are from local health departments, I just wonder if there's any comments you might have on, is there something local health departments should be more attuned to, they should be aware of? Are they informed about ATCs that might be within their jurisdiction? Is there any kind of communications happening between a local health department and an ATC that might be within their boundaries?
We don't have any initiatives at the moment. That's not to say that we're not open to establishing whatever relationship is helpful. The question of whether or not there's an ATC in a public health department's jurisdiction is easily answered right now by going to the website, and then not so straightforward on the website, but the locations of where the 6 new ones intend to operate, that's out there in media reports, but I can give you that real quick. The 6 new are Patterson, Phillipsburg, Elizabeth, Ewing, Atlantic City, and Vineland. 2 of those, I know that Phillipsburg is going to grow in Boonton, I believe. So the cultivation facility will be in Boonton.
Okay, Morris County, I think.
Yeah, Morris. If you didn't know it was there, you wouldn't know it was there, because nothing else will happen except people will come in and trim plants. And then the Atlantic City operation intends to grow in, I believe it's Galloway.
Okay, also Atlantic County, I think.
Yeah. So, there are, Patterson, I think, is going to be all co-located in the same place. Elizabeth, the same thing. So, yeah, we're open to working with public health departments if there's anything that we can do or we can provide.
Okay.
We don't currently have an established role for them, but completely open.
Thank you. Right. And I think if nothing else, it's an education just as much for local public health as it is for anyone else. This new territory for local public health. So, well, I don't see any other questions coming in. So with that, Sue, thank you so much. That was incredibly informative. As a reminder to everyone who's participating today, this program will be recorded and posted to our Rutgers Training YouTube channel. I will resend that link to everyone who's been registered. Again, it'll also make its way to TRAIN, the National Clearinghouse for Public Health Education Programs. And with that, thank you all for joining us and have a great day. Thank you, Sue.
Thank you very much, Colleen.
Have a great day, everyone.